And I guess this is the last session of today. So we have online panelists, Dr. Wahaj Aman from USA, Dr. Atif Bashir from USA, and Dr. Fahad Wakar from UK, and also Dr. Rizwan Khalid from USA, Dr. Javed Suleiman from US, and Fahim Jafri from Singapore, and they'll all be joining us online. And our physical panelist who is going to be sitting here on the stage, Dr. Shaoling Chen. You want to stay there or come up on the stage? So you prefer there, I mentioned. And Dr. Bashir Hanif is not here right now. Dr. Jabbar Ali. Okay. Dr. Naeem Mangal. Dr. Asim Javed. Dr. Arshad Ali Shah, Dr. Naeem Malik, and Chirag Hussain. Dr. Sid Pathan would be moderating the session with me. So we have a live case from Oklahoma Heart by Dr. Naeem Tarkhili, who has been very supportive of Park Live, and we have a WhatsApp group who's very active, always giving great input over there and sharing his cases there as well. So you have a big fan following over here in Pakistan. Can you hear us, Dr.
Tarkhili? Yeah, can you hear me?
Yes, we can hear you well. So what do we have
there?
Who
am I talking to? I just got into the... Can you hear me?
Yes, we can hear you well, yes.
Okay, so we have a very interesting case, and Bajahat Lodi from Foundation Medical University, yeah, and Dr. Samiullah from Hayatabad Medical College just came in late last night, so they've gotten up, and Bajahat has your patient ready for history, so I will let him talk about that, and then we'll get to the case.
Right, so welcome everyone. So this is a patient who's male, 65-year-old,
frequent
had a history of sudden cardiac arrest in 2005, for which an ICD was placed. He remained comatose during that procedure,
take the guideline
and with recovery and treatment, he did an uneventful recovery. Was doing well up to 2015. 2015, he had symptoms of angina, chest pain, underwent a coronary angiogram. There was a critical RCA that was fixed with a 4x18 bare metal stent. We put in a workhorse wire, which is Samurai, and right at the knob, you can see the J score is pretty high in the CTO. It's calcified, has a branch at the proximal knob, and it's blunted. So we put a force here at the knob, and we have Fielder XTA wire, and we are trying to find a channel through it.
Fielder XT, not XTA. Okay. All right. Let's keep going. See what you got. Okay. Jay, can you give one of them a mic?
So while he's working on crossing, can you just go over what are the hemodynamics before and the indications for Impella over here? There was not as much clarity in the history part. We heard that somebody came in with MI, cardiogenic shock, and with multiple PCIs in the past. Last one was in 2015. What was his EF and what did his coronary artery look like?
So when he came in initially in 2005 with sudden cardiac death, that was a non-ischemic cardiomyopathy.
Okay.
And so at that time, he was comatose for several days, had some cerebral hypoxia. We recovered him. His EF was 15% at that time. So got a dual ICD and all the guideline-directed medical therapy. And so we continued to follow him, and then he became ischemic, had symptoms, had some VT. And so in 2015, he had a bad right coronary artery calcified lesion, got a stent at that time. And now he's just getting intractable VT. He's on amio and mexiletine. Our EP, you saw Dr. Jewell yesterday.
And we lost you there. Can you look into it? So So while we're trying to connect any thoughts from the panelists, I guess they're doing on somebody with the recurrent VT, which is thought to be ischemic, and his EF apparently did get better on guideline-directed medical therapy, and
So how long was the CTO? Do we know the CTO is recent or?
So that's.
I think this is Fahim Jafri from Singapore. I'm just unclear. The CERC CTO was known before, or is it something that just?
No. So he got. Can you hear me? Okay there.
Yeah.
So
okay. So he had.
We lost you again.
Yeah, it's very frustrating.
So the right was fixed in 2015,
15,
right? Something like that.
I'm assuming the right is okay
so
right now.
There's a 1 or 2 second delay. Can you hear me?
Yes, we can.
Okay. So he had intractable VT, not controllable with amiodarone and mexiletine. And so the EP person said, hey, can you look into coronary? Okay. And we did a stress test, and that was very positive and infralateral, partially reversible. And this angiogram is 2 days ago.
Okay.
I hadn't done an angiogram on him for several years. He had been doing okay.
And so RCA was okay. The stents in the right were patent. The RCA was okay. Right coronary artery was okay.
So right coronary artery stent is okay, but there's not much of right to left collaterals. So that's why.
And what's his current ejection fraction? All right, we lost him again.
If we would put an impella or not. The plan was not to put an impella in. But my issue is
I'm sorry, we lost you. What was his ejection fraction? We lost you in between what you were talking. What was his ejection fraction?
His ejection fraction
during this admission.
I think it dropped, right?
His ejection fraction is 30%.
30%, okay.
So the reason for impella, let me go over that again, is because there's only left-to-left collaterals, not right-to-left collaterals. When we go into the CTO, we'll end up dissecting it. And as we dissect, if we inject from the left side, where there's the only left collaterals at that time, large hematoma. So to try.
We lost you again.
I guess. Now we can hear you, but the picture is frozen here. Now we're back again, yeah.
Hear me okay?
Yeah, yes.
Okay, so what I was saying was we have left-to-left collaterals. We do not have right-to-left collaterals. To go and work on the CTO, we'll have to inject left side. As you go into the occlusion, CTO, you're essentially causing dissection, and if you inject through antegrade at that point, you're creating more hematoma. So essentially, all the CTO operators will tell you that once you get engaged into the CTO, you stop injecting antegrade. Everything is retrograde.
Again, we have a connection issue. So your thoughts from the panelists regarding the use of impella, EF 30% for recurrent VT. We're doing this, I guess they had infralateral ischemia, and they thought left circumflex was a likely source because of the ischemia for the VT. That's why they're attempting the circumflex CTO first. Any thoughts from the panelists regarding the impella use and the approach they would take to this CTO?
Yeah. So we're not connecting very well. So I was on the previous section also, and we were having a hard time listening to you guys at times. So this morning something is going on with the Zoom. I'll try to explain that again. I've gone over this like 3-4 times now.
We heard your part of the approach, why you're doing circumflex and what you're planning to do. So we got that part.
Very interesting part. So when you do a CTO, there is antegrade and retrograde. Once you engage antegrade, you stop injecting antegrade. Because if you inject antegrade, a lot of times you'll create a hematoma because you're essentially causing, when you're going in, a lot of times you're causing dissection and you'll create a hematoma. Here, since there is no right to left collaterals, and I'm going to have to do a left-sided injection to see my distal vessel, what I'm choosing to do is put a big guide liner into the circumflex through the left main, which then will occlude the left main or compromise the left main and already have an EF of 30% with recurrent VT. So that's my thought, is to potentially put in an impella for safety purposes.
Good idea, yes, absolutely.
Okay.
I think most panelists will support that. And Asim, you had some comments, you wanted to say something?
Yeah, thank you very much, Dr. Naim. Very interesting case. It's Dr. Asim Javed.
Huh?
So,
Okay.
we totally understand your point of view for using impella. I was just wanted to making a comment regarding the antegrade injection when you've got collaterals cross-filling from the same left side. We haven't seen the angiogram in that detail, but I'm sure you must be having some collateral there which you maybe can selectively put your microcatheter there and use that for retrograde injections. But then you've given us the other explanation for using impella, because you want to use a guide liner and that might occlude your left mainstem and make the patient unstable. So that makes a lot of sense. Yeah, thank you.
Yeah, exactly.
All right, so where are we with the wire now?
Okay. So Heather is now using, Heather is now working.
I will show you more pictures of the whole CTO thing and you know, the way it's filling, and there's just one area called view, but in which.
Okay. 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 That's okay. Did you have an angio? Okay. Let's just do some and see what we got. Okay. Ready? Okay.
What microcatheter are you using in the Fielder XT?
This is Corsair XS, Naman.
Okay.
So one of the things about CTO and CTO operators is rapid change in your strategy. And as you get adept at this, Naman, as you would know, and the rest of us, we are able to figure out immediately that this thing is going to work or not work. And sometimes nothing works, obviously, but this Mongo is not going to go anywhere. So I'm switching to G2, and we'll see what that looks like.
Okay.
Okay.
Naim, from the angiogram, we can't see it very well. What is the course of the vessel? Is it sort of very tortuous, or is it fairly a straight shot?
Huh? Just come closer. This is the whole thing. You got to be able to see it better. And then did you give mic to either one of them? But again, remember, this is Gaia 3. So as soon as I cross the lesion, I want to change out for something that's not that stiff and heavy tip. My problem is I'm having a hard time getting across. So now I'm a trap liner. So trap liner, as folks in US know, is a combination of guide liner and trapper together. So we went up. We're going to take this out. Let's take a 1.0 balloon, guys. Yeah, let's get me a Sapphire. Down. The other thing, whoever uses trapper, and I know a lot of people in Pakistan use the balloon.
Yeah, we use the balloon in the guide catheter, or you know, you just inflate the microcatheter and get the wire out through that. But we don't have the trap liner here, and even if it was, it will be a big cost issue using it in our cases.
Turn my light up. always be aware that whenever you go up with a trapper, you will always have air in there. So do not inject once you've done a trap maneuver. So can you see this real carefully? Trying to see this? Always be aware that you're going to have air in there. So you can do everything right and then inject air in there and shut everything down. So just small little things to remember. Got the balloon? Yeah.
Which balloon are you taking?
I'm just going to the Sapphire, 10 millimeter long balloon.
Dr. Naeem Bengal, or any of the panelists have any other comments? Yeah.
I was wondering.
So once we get across, my question to you guys is, this is, to me, this is good 4.5 millimeter artery. You guys want to do a rota, you want to do a CSI, or would you rather just, if I can get an IVL in there, would you rather do an IVL?
Before we decide on that, once you balloon, we would like if you can get an IVUS catheter across, get us the imaging, and then I think we can plan better what will work, IVL, rota, or CSI. We don't have CSI or experience in Pakistan, but yeah.
No, 100%, but my thought is to see what you will think at this point.
I think that the bend in the artery and that curvature would worry me, so I agree, do an IVUS and see, maybe an IVL is going to be enough. But if you need to ablate, then ablate very cautiously. One option is CSI going back, but it's a very tight lesion, so I think if you're going to use something, it'll be rota, but that curvature bothers me a little bit.
I guess
I agree. If I'm going to use this, if I did not have IVL, I'd probably, and I don't know if Bakas is here or not. He's a great CSI operator.
So while you're working on the CTO, we have Professor Tanveer Rab with us. He's going to talk.
I kind of try to avoid CSI. Obviously, you can come back. Go up.
So we have Professor Tanveer Rab with us. He's the author of the guidelines on bifurcation lesions. So good to hear from him directly about left knee bifurcation stenting. We're going to let you work on the CTO and come back to you, okay? Dr. Khalil?